Welcome to the CMEssentials podcast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello and welcome to another installment of Oakstone's CMEessentials in Hospital Medicine. I'm your host, Dr. Monique Lucarelli. I'm a board-certified internist with experience teaching residents and hospital medicine fellows. I've been a part of Oakstone's practical reviews in hospital medicine team for nearly 10 years. Today, I'm joined by Dr. Sarah Murray as we discuss the role of artificial intelligence in hospital medicine. Dr. Murray is the perfect guest for this session. She is Vice President, Chief Health AI Officer for UCSF Health. She also serves as Associate Chief Medical Information Officer for Inpatient Care at UCSF Health. She is Associate Professor of Clinical Medicine and Associate Chief for Health System Partnerships in the Division of Clinical Informatics and Digital Transformation. Dr. Murray, welcome.
Thank you so much for having me.
Our discussion is presented in two parts. In part one, we will provide a brief, basic overview, then dig into using AI to improve patient communication, and finish with tips on using AI to improve care without adding to alert fatigue. In part two, we'll talk about using AI to augment provider care and avoiding AI pitfalls and risks. We'll end each part with key take-home points. Before we dive in, Dr. Murray, please tell us a bit about yourself, your background, and your experiences bridging the human aspect of relating to patients and the technical aspect of interfacing with machines.
Yeah, sure. So I've spent the majority of my career really focused on the interface of healthcare and technology. And that began with my work as a health services researcher, where I was using machine learning to identify rare diseases in the EHR, the electronic health record. And that continued through my work where I was doing more traditional clinical informatics, optimizing how we use the EHR to deliver patient care. And now in my role as a Chief Health AI Officer, I'm really responsible for the vision and strategy for the use of AI in the health system. My goal in the health system is to use data science and AI to solve the most pressing problems in healthcare. I want to make sure our AI implementations are safe and effective. And a critical part of that is really thinking about the workflows and specifically how providers and patients can and should interact with AI tools.
Thank you, Dr. Murray. There's an explosion of interest in AI now that we're seeing tools like ChatGPT on the market, but AI has been around for a while. Can you explain what makes generative AI different?
Yeah, so your point is well taken that AI has been around for a while, but much of what we have used historically in terms of predictive models is what I call traditional AI. So there are many different techniques for traditional AI, but to oversimplify a bit, if you had a stack of photos of cats and dogs, traditional AI would be able to identify features that make them different and then sort the photos of cats and dogs with some variable certainty based on those characteristics. Generative AI is different in that you can describe a cat and it can generate a reasonable picture of what a cat might look like. So likewise, you can give it a text prompt, which we do with tools like ChatGPT, and it's going to generate a reasonable written response.
Okay, now how does AI differ from the search engine that we all know and love?
Different search engines do this differently, but without getting into the details, when you search the internet, you're really focused on retrieval of information that best matches what you're looking for. AI, and specifically generative AI, is different in that it creates context-specific responses in response to a prompt after being trained on a large corpus of information, such as the internet. Some of the newer models are able to provide references, but retrieval of website or references is not usually the main function of generative AI.
Okay, I keep hearing about new versions of AI chatbots. For instance, Chat GPT 4.0 versus the free 3.5. And now I hear that a 5.0 version could be released in the second half of 2024. How significant are the differences between versions, and what are we doing to make them better with each release?
Things are moving really fast here. ChatGPT 3.5, which was what most of us initially used, had about 175 billion parameters and was trained on data up to September 2021. GPT-4 Turbo was a much larger model, and it was trained on data up through December 2023. And now what was released just a few weeks ago was GPT-4o, which is the newest version. And interestingly, the goal was to make it faster and cheaper while maintaining high performance because GPT-4 Turbo is very expensive. But they actually ended up with a tool that was comparable on text, significantly better in certain domains like mixed media, while being about 50% cheaper and faster. So we will see what's next. Interestingly, I think if you ask the folks at OpenAI what 5.0 is going to be, I bet they can't even share the details because it's hard to anticipate with how quickly things are moving. But I expect we're going to see dramatic improvement over the already good tools.
Okay, and just to clarify, by mixed media, you mean picture, graphs, as well as text?
Exactly. So taking in text, photos, videos, different types of media at once.
Okay, and also just to clarify, correct me if I'm wrong, this data is still only what's publicly available, correct? There's no access to copyright protected material or paywalls?
Yeah, it's publicly available data. Now, different businesses are doing things with their specific data as internal use cases, but what I'm talking about with ChatGPT is publicly available.
Okay, thank you for that clarification. Dr. Murray, can you share with us concerns about confidentiality and how best to preserve patient safety using these tools?
Yeah, so it's really important to know that while these tools are open and available to the public, and it's very exciting because we can test them for many different types of potential clinical use cases, the open and available tools are not HIPAA compliant and are not an appropriate place to put secure patient data or any kind of patient data. And so I encourage you, if you're testing them, to test them generally and not with real data. But it is important to note that the industry is responsive to these needs for health systems and providers, and companies like OpenAI are now beginning to release HIPAA compliant tools like ChatGPT Enterprise, which organizations can choose to purchase for use in clinical care.
Now, let's dive into the clinical ramifications, particularly as they impact hospital practice. We'll start with AI and patient communication, specifically patient record summaries. Dr. Murray, in a recent article in Today's Hospitalist, you talked about how most success with AI has been experienced at larger institutions like yours at UCSF. But that things are about to change for hospitalists who practice at institutions big and small and in between. You borrowed a term from Dr. Eric Topol, keyboard liberation. Tell us what you think is on the horizon and how it will impact inpatient care and communication with patients. Before you answer to our listeners, there is a link to the Today's Hospitalist article in the show notes that accompany this episode. Go ahead, Dr. Murray.
Yeah, so I think AI scribes are going to be the biggest thing here. Health systems are already implementing them across the country, and they're really set to become a commodity. I think they're going to change the experience of a visit for both patients and providers. So no longer is your doctor going to be furiously typing while speaking with you. They're going to be looking directly at you, the patient, during your clinical visit. And that's the initial feedback we've gotten from both patients and providers. Providers are experiencing this tremendous relief of cognitive burden because they can actually look at their patients, and patients are having these newfound experiences, more direct engagement with their providers, which is really nice. A lot of the focus right now is on the ambulatory clinics, but I think it's going to infiltrate the inpatient settings soon. And these tools aren't just going to be doing scribing. So they're going to do a lot more. They're going to help you pen your orders, They're going to help with medication reconciliation. They're going to do a lot of the things that are critical in our admission workflows and things like that, or at least pen those things for us. Likewise, a number of tools, and when I say a number, many tools are being released by EHR vendors like Epic, and those promise to help us with a number of tasks. In the hospital medicine space, I'm really most excited about summarization. Anyone who's done inpatient medicine knows how tedious it can be to really properly review outside hospital records or complicated ambulatory care that's been delivered for a newly transferred patient. And so, if done right, I think AI summarization tools are going to be tremendously beneficial in limiting the amount of time providers have to spend in front of a computer. But we really have to make sure that they're safe before we deploy them widely.
Okay, well, it sounds like AI will essentially come in the form of new tools embedded into the EHR that we already are familiar with. Regarding patient record summaries, how is AI being used for improved patient understanding?
Yeah, so I think there's a lot of promise for using these tools to quickly distill information into various reading levels or languages. And we're just beginning to test the safety and trustworthiness of these tools for those purposes. I'll say right now, you're not allowed to use them for translation according to CMS guidelines, but we're looking at whether they can distill information at various reading levels. And certainly patients who have access to their notes are doing this themselves. They're taking their clinical notes at their own will, and they're putting them into these tools to help consume them. I think one of the things that's important here, because we know these tools are open and available to the public, is that we really learn how to talk to our patients about the risks and benefits, just like we talk to them about the risks and benefits of what they find on the internet. And so I think in the next maybe 2 to 3 years, we're going to have a much better understanding of how to safely and effectively use these tools directly in clinical care. And as we learn that, they'll be safely integrated into the EHR as well.
How is AI helping improve patient to provider communication and provider to provider communication? How do you anticipate that AI will affect hospitalist workflow in the next 2 to 3 years?
So most of the impressive work that's happening right now is around streamlining both the generation of clinical documentation and then the consumption of clinical documentation. And as I mentioned earlier, I think the biggest thing happening in this space right now is AI scribes, or what will become AI assistants. But these companies, as I mentioned, are exploring tools that are going to help with things like chart preparation, which is essentially the review of the patient's history that's necessary to have that encounter with the patient that day. We're also exploring the use of these tools for things like drafting after visit summaries and patient instructions based on clinical notes. But again, all this is very early. And as I mentioned, these patients are at liberty to use these tools too. They're open and available on the internet. So whether we like it or not, it's not going to be unusual for patients to have had discussions about their symptoms with AI like ChatGPT and then come prepared in their encounters or visits with us for questions based on those interactions.
I think that's a really great point. For the fun of it, I did a GPT search on what to ask your doctor if you're about to have a hip replacement surgery, and it just gave me a nice little summary that I could imagine a patient could take with them to the office.
Yeah, exactly.
This is a good time to introduce a case which we will use to demonstrate how AI can be used to improve communication and documentation, resulting in better patient experience and outcome. And Dr. Murray, I'd appreciate your comments on this. Sheila is a 75-year-old woman who, despite multiple comorbidities, remains committed to living alone in her own home. She suffers a fall at home and is briefly admitted under observation status due to a possible loss of consciousness. The following morning, she desires to be discharged home. Her discharge summary is prepared as quickly as possible using a standard template, which carries the disclaimer, all abnormal test results to be followed up by the outpatient team after discharge. Sheila follows up a week later in the PCP office as recommended by the discharging physician. Unfortunately, her PCP could not come to the office that day due to a positive COVID test the evening before. A covering physician is double booked and asks Sheila how she's doing. The patient states the bruises are healing and she feels better. She reports happily that all my x-rays were fine. The covering PCP decided to use the new Office AI capabilities to summarize Sheila's hospital test results and progress notes. She reads that the radiologist has noted an incidental finding, a small adrenal nodule, not specifically noted in the discharge summary. The patient has no recollection of being told of the nodule, and both the patient and PCP are thankful for the clarity of the summary, and the patient is scheduled for appropriate follow-up imaging. Dr. Murray, what kind of role do you think AI could play in the care of this patient?
Yes, I think you've highlighted a couple things in this example. First is, in general in healthcare, there's a gap in tracking these incidental findings, but many health systems have put into place safety systems that can help us make sure things like incidental pulmonary nodules are caught. So if you're trying to solve that problem, AI may not be your best approach. Radiologists can simply drop electronic flags in the medical record when they see things like a pulmonary nodule, and that can trigger a set of technology-based actions that aren't really AI-based, but ensure the patient gets the care they need. And I highlight this because it's really important that before we think about AI as a solution, we really need to think about the problem we're trying to solve and whether AI needs to be the best approach. The second problem you're highlighting here is that after hospitalization, it can be really difficult to distill everything that happened to the patient that is relevant to the primary care doctor. And this is an area where generative AI summarization tools can potentially be very useful, but they have to be tested carefully because in this example, the only way to know that the tool is missing something critical is to do the very thing that the tool is trying to prevent you from doing, which in this case is reading the entire chart. And so there's a lot of validation that's needed before we can be confident about implementing these tools in clinical medicine.
That's very interesting. I just wanted to highlight something you said. So you're saying that if you use a summary, you'll actually not be able to read the entire reports for yourself. Is that kind of what you meant?
No, you certainly can. And right now, I would say you should. But the reason we're thinking about developing these tools like summarization is because reading the full record is very time consuming and tedious. And so the risk is that if we present a summarization tool to a clinician, but it doesn't pick up all of the critical information or it misinterprets some of the clinical information in the patient's chart, that could be missed because the physician would rely on that in lieu of reading the patient's chart.
I see what you mean, sort of trust but verify.
Yes.
So are there any other ways that you think that AI can or soon will be able to help improve Sheila's experience?
It sounds like Sheila lives at home. She has multiple comorbidities and she's susceptible to falls. There are a lot of tools that are being developed to support remote monitoring and even hospital at home functionality, which I suspect will have a lot of AI embedded in that technology. And hospitalists will play a role in utilizing that technology. And all of these things may be beneficial to Sheila if she continues to prioritize wanting to live at home alone.
Let's move on to discuss alerts and reminders. Those of us who work in hospitals receive a seemingly infinite number of alerts and reminders. How can AI help us manage all these alerts more efficiently?
Hospitalists and even more so nurses in the hospital get a lot of alerts. And when we get too many false positive alerts for something like telemetry, there's a risk that we miss the important ones and something bad can happen. That's a phenomenon called alert fatigue. I do think there's a real opportunity to use AI to refine a lot of our alerting processes. So where an algorithmic deterioration alert may fire a lot of useless alerts, AI may be able to help us pare that down a bit so that more of the alerts going to the end user are something that can be intervened upon, and that will be helpful in reducing overall alert fatigue. With regard to reminders, and I assume by this you're thinking about patient-facing reminders. There are a lot of technologies that do this already, and I think AI is going to help us get better at sending the right reminders to the right person at the right time.
I'm going to move on to other uses for improved patient communication. There are several other potential uses for the hospitalist I'd like to learn more about. Sticking with our approach of discussing what's available now or soon could be available, I want to ask a series of rapid fire questions regarding these different areas. Let's start with medication reconciliation.
I think AI-assisted med rec will likely come in the next few years. As we start using these AI scribes during encounters, the system should be able to check what you were discussing with the patient against what's already documented in the medication section of the electronic health record, and at the very least, pen the changes for us.
And what about automated billing?
There's a lot of focus on this area already, and there are many tools already on the market to help with things like clinical documentation integrity and charge capture. So from the physician standpoint, I think a lot of what we do to ensure appropriate billing will be streamlined with AI in the future. And I think our billing colleagues are going to have a number of tools that help them on the back end as well.
Is AI able to provide second opinions yet, or facilitate a second opinion provided by a human?
It's a great question. We're just beginning to explore this. So we're doing something called retrieval augmented generation, or RAG, where we basically ask tools like GPT-4 to answer clinical questions while referencing specific clinical guidelines. So there's a faculty member in hepatology at my institution who's done this with liver guidelines, and it's incredibly good at answering questions about hepatology guidelines. So we need to test these tools, but I think in the future, we're going to be able to use AI to help democratize subspecialty knowledge.
That is very exciting. And what about AI for triaging?
There have been a number of studies in this space as well, including a recent one from UCSF showing the potential of AI to do triaging based on acuity in the ED. And there are also tools for triaging things like radiology images. I don't think any of these tools have dramatically transformed care delivery yet, but I think they're also in line to get much better over the next couple of years.
Okay, let's close out episode 1 by summarizing some key take-home points. Number 1, AI is here and will be increasingly used in medical practice. Expect to see it in the form of tools incorporated within the electronic medical record. Secondly, confidential patient information cannot be used to query free open AI models. Most major hospital systems already have HIPAA compliant ways to use AI. Hopefully, we will soon see closed AI models within all hospital systems, which are HIPAA compliant. And finally, AI functions best as an assist to human work, not a replacement. Providers need to review AI output and correct errors as necessary, keeping in mind the provider is still ultimately responsible for the care provided.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CMEessentials in Hospital Medicine. To learn more, visit oakstone.com.